associate director, serving as the point person for data science, collaboration in biological sciences and health sciences. His research is funded by the NSF, NIH, Department of Defense, and private companies, and focuses on the design of computational systems using advanced signal imaging processing and AI for clinical applications, including computer-aided decision support systems and drug design, with the goal of improving patient care and reducing the cost of healthcare. In particular, he focuses on creating decision support systems to manage traumatic brain injuries, respiratory illnesses, cardiac arrest, GI diseases, and other critical care states. He has over 40 patents in this field, some of which have been commercialized through industry partners, including startups and large corporations. Emily Wittrup, is that right? Is a senior computational biologist and research manager for the biomedical and clinical informatics lab at the University of Michigan Department of Computational Medicine and Bioinformatics, where she was also a PhD candidate under Dr. Najarian. Prior to her current role, she gained valuable experience as a data scientist for a health system, where she developed a passion for harnessing computational methodologies to advance medical research into practice, improving patient outcomes. Her current research includes developing clinical decision support tools, including advanced image processing and deep learning methodologies for medical conditions such as heart failure, strokes, and traumatic brain injuries. She also leads multiple projects utilizing generative AI to accelerate drug design. I'd like to ask you guys to give us our speakers a warm welcome. Thank you.
If I realized you were going to read that, I would have given you shorter.
Yes.
We're excited to be here this morning with you.
Thank you very much for inviting us here. So before everything, I want to acknowledge our sponsors. So it wouldn't be possible to have this presentation without the support of these sponsors. Also want to have like a quick disclosure of my involvement in this company. Some of the technologies that I talk about have been basically licensed to these companies, and I have some share of these companies as well. Can move to the next one. Then we want to acknowledge the faculty in our lab who are also essentially the people who created these technologies. I see you recognize some of the familiar faces here. Ryan sitting in the back. Thank you very much, Ryan, for your support. Dr. Oman, our mentor in the lab, and also you know that Dr. Coney, unfortunately, he left us, but you will see a bunch of projects that we present today that Joe has been heavily involved in. Daniel Ehrman, I'm sure you're familiar with Dan, who's also leading some of the projects that I'm presenting today. And many other people here that I'm confident that you have been interacting with, and we will hear about some of the projects that these people are leading in our lab. And then we'll discuss next slide. Obviously, Emily, who's our research manager, you hear about some of the work that she's leading. We have an operation manager who's essentially like running everything for us in the lab, visiting faculty, research faculty, and postdoctoral fellows. And we have an army of graduate students and undergraduate students who are actually the people who are doing this, and we're presenting on their behalf. So basically, these are the engine of our lab, and these are the people who are sitting and doing the work that you will hear about in this talk.
Can I maybe give one interjection here? So we're excited to share some of our recent research with you, recently published research, and then look forward to maybe discussion with all of you about how that might apply to some of the work that you're interested in, or the research fields that you're interested in, either now or in the future. So as we're going through these projects, just kind of keep that in the back of your mind as we kind of move toward the discussion piece of like how are these concepts, maybe algorithms and or approaches applicable to all of your research?
Absolutely. So let's start with our philosophy and what we do in the lab. So we are AI people, so we design artificial intelligence and machine learning algorithms. And this includes like signal processing methods, image processing methods, algorithms that we design for different types of applications. We analyze data and we extract knowledge from it and we create recommendation. And majority of our work is focused on creating clinical decision support systems, creating recommendations and analyzing the data to have some insight about what is happening with the patients. We're very curious people and we want to do discovery, but at the same time, our objective is to create recommendations and create like solutions that become available for clinical support. In other words, we like publications and probably our lab normally publishes between 15 to 20 journals every year, but publication has never been our objective. We don't define the success of any project by the number of publications. We evaluate the success by whether at the end of the project we create a solution that actually goes in the hands of clinical practitioners to actually use it. As a result, we work very closely with industry because universities don't sell anything, don't get involved in commercialization. We work very closely with industry, as you saw at the beginning, that often whenever we get to the point of feeling that the project is ready, we start working with industry. Maybe 70 to 80% of anything that we do at some point or another gets licensed to companies that they try to bring it to basically the bedside. Often we create, like I said, clinical decision support systems, but that goes to many different fields. It goes to cardiology, critical care, neurosurgery, GI, different fields, and that goes for adults and pediatric cases. And you will see that, the projects that we present as samples of the work that we do in the lab, they always have pediatric component and they have adult component. And we talk about both of them in here. So our philosophy is to make sure that what we do has a path towards becoming something that people actually use it, as opposed to just discovery. It's part of that. So we hear about computational methods these years. So I created something called a galaxy of methods, and you hear all these buzzwords, and most of them, they have so much overlap that if I actually wanted to show the actual overlap of these things, it would be something that you could not see the words because they just overlap, right? But in reality, you hear about data science, the big sort of overlap here. And you have machine learning, artificial intelligence being like a big chunk of that, and big chunk of artificial intelligence being machine learning, and a good chunk of that being deep learning, generative AI, and the part that is these days becoming very popular and making the whole field very significant. You hear about that in the news and you start seeing everybody's using that, is large language models, which is, I want you to see that this is only just a very small part of the whole galaxy that we are dealing with. So large language models that gets a lot of attention and gets most of the highlight these days are actually very small part of this whole galaxy that we are dealing with. And every day we have to deal with using different techniques for different applications. And what you hear today probably would represent this idea that we are using a lot of large language models and small language models that we create in the lab, and Emily will talk about some of that in our projects, but you will see that there's a whole lot more in here that we use for different applications. So if we go to the next slide, using AI and machine learning creates a lot of challenges and opportunities. So this challenge tree, I created that a few years ago for government of Canada. They wanted to have, they were starting a new branch in Ministry of Health focused on AI, that they wanted to see what are the main opportunities and challenges that they wanted to structure that division within Ministry of Health based on these particular sort of challenges. So obviously, you have technical challenges. Some of them are data related, some of them algorithmic related, like how to validate these models, how to make sure you create large databases, and how to rely on these models. And then you have health and clinical aspect of that, legal, ethical aspect of that. And of course, like another aspect of that is socioeconomic, cultural side of that, like equity, transparency, those things that now we realize that if not more important, they're as important as the rest. So why we understand and appreciate the importance of all these three branches of challenges, my lab mostly focuses on the part that is highlighted as yellow, like technical side of that, because of like the type of training and expertise that we have in the lab. My lab is probably has at any given point between 30 to 40, 35 to 45 people in it, different levels, like, you know, and probably 20 faculty on top of that, different groups involved in it. Most of the people are basically working on the technical side of this. So we thought that the best way of organizing this talk would be we go over a few of the projects that we have done with the team, like, you know, Ryan, like, you know, we will hear about some of the projects that Ryan has been leading. So we thought that we give you some samples of the work that we do so that you get familiar with the way that we work and the like kind of projects that we do. In the end, like we have one slide that talks about other projects, and like just like, you know, as a list, we talk about some other projects. So you get a sense of like the work, the kind of work that we do, the kind of like, you know, approach we have. We don't get into technical side of any of these things. We don't get into any details, just to give like an overall idea of the kind of work that we do. And then, like Emily mentioned, we go into discussion and see what we can do to help you with your work. So first one that we're going to present, that these are like, you know, clinical leads for this project has been Dr. Barbaro and Dr. Schoding, was segmentation of lungs in chest X-ray, mostly like for all cases, all different types of cases, but most specifically for ARDS cases. And this happened for both adults and children. Mike was helping us with the adult cases, and Ryan with children. So if you look at this, you hear about all these publications and products and things out there that are talking about, like, you know, segmenting chest X-rays and identifying, like, you know, the borders of, like, you know, lungs and everything. Majority of them, they're working on clean cases. Clean cases means, first of all, they don't include like a lot of, like, you know, pathological cases, like, you know, looking at like disease cases. They're mostly healthy cases. And more importantly, they're not dealing with the cases that you have electrodes or you have prosthetic devices and things like that. Like if you get to those ugly cases that are the images that you're dealing with, they're kind of like corrupted by all kinds of like other devices and things like that. Those techniques normally fail. So the objective of this particular project was to deal with the difficult cases, right? So those algorithms, when they work with clean cases, they report very good AUCs, like or DICE in this case, they report very good AUCs, but even in those cases, they have a ton of, like, you know, variance, and shows, like, you know, this thing can go up and down a lot. But we wanted to focus on those like difficult cases, both for adults. Majority of the X-rays, if not all of them in these cases, they're all adults. But the data that we're presenting in this box in here for you, these are all pediatric cases. Half of them are ARDS. And we wanted to use this algorithm that I'm not going through the algorithm, just like telling you that this is combination of two techniques, like, you know, active contour technique and total variation algorithm. We combine them to create like a sort of cohesive algorithm that deals with these variations that we are dealing with. And for that type of really ugly cases, let's put it this way, these are not clean cases. For clean cases, we managed to get a very good DICE, but very small variance in the sense that the algorithm is very robust. It doesn't go up and down. It doesn't give you a horrible thing. And in some cases gets like very good results, right? We wanted to focus on the robustness. It doesn't matter that it it's slightly less than the dice. Like dice is a metric that tells us like how good the segmentation is, right? It doesn't matter if it's slightly less than that, but it's more robust. And that is the direction that we are moving with our segmentation. Most of our, not just for this project, for other projects, for us, it's important to have robustness and repeatability, as opposed to just having a bigger number that you get on good results and just, fail on reproducibility of the results, right? So that's a project that we started a few years ago with Ryan, and we continue working on it, and we try to like create even bigger databases and, enhance our algorithms. Next project that we're gonna talk about. So that,
Question.
yes.
So with that, what can you do, right?
So this next slide, next project is exactly what we do.
Okay.
So now if you can segment these images, you have the ability to analyze the X-rays. Now, how we want to integrate that into the sort of the pipeline of decision-making for diseases, right? So let's go one step back and think about these are the things that Ryan and has basically taught me through this process. Like for this project, we work with Mike Shoding and Ryan, and this is what I learned about like what happens with ARDS cases, right? So you get patients, and for a while you have only access to EHR type of data. You have what you can see in typical clinical assessment, and you don't have chest X-ray or anything because nobody has even suspected that it could be ARDS to order chest X-ray and look at the chest X-ray and see if there is even ARDS, like saying bilateral, So you, at this point, before you even order chest X-ray, you don't have any information. You have just the clinical information, right? So I call it, this is preliminary stage that you need to best utilize the information that you have at that given time. But the question that we're asking, is it possible, even though you don't have the chest X-ray yet, is it possible to train a machine learning algorithm that even though you haven't collected chest X-ray, to have a machine learning algorithm to tell you that this would be diagnosis if you had access to chest X-ray? I mean, it's a kind of impossible kind of situation, impossible kind of prediction that you don't have chest X-ray, but you're saying, what if you had access to chest X-ray? I'm gonna say that this is what is happening in the minds of many of you clinicians all the time, because compare two cases, like an experienced clinician and a doctor that starts like day one, right? An experienced clinician who has seen so many ARDSs in the past, and a novice one, like a clinician who starts day one, they're both presented, they're given like the same patient, right? A clinician who has seen many of these patients in the past, just by looking at this like clinical data, since they have seen so many patients like that in the past, just by looking at this clinical data, they know that these clinical patterns are often associated with something in the chest X-ray. And even before seeing the chest X-ray, they feel that if they order chest X-ray, they expect to see something in chest X-ray that suggests ARDS, right? That's why they order chest X-ray. Most of the time a new doctor wouldn't do that. So from my machine learning point of view, the brain, the AI that they have in their head is trained in a way that just by looking at this data, they can somehow come up with the idea through the training that they had in the past that this has some information about the chest X-ray that they even seen through the experience. The question that we were asking ourselves in the world of AI, can we train AI, which we call it privileged learning? Can we have privileged machine learning that would look at the, like, this data without having access to the chest X-ray, to even before X-ray becomes available, make a prediction that this is ARDS by having the experience that the experienced clinician has. Yes, we can do that because when we are doing the training, in the training phase, we have access to everything, including chest X-rays. Can we go to the next slide? I'm not gonna go over the process, like the detailed process of that. But in the training, I have access to everything, including privileged information. And privileged information is the chest X-ray that is reported for these retrospective cases. For these retrospective cases, we have access to chest X-rays, both positive and negative cases. So in training data that is rich enough, that has both like positive and negative cases, I can train the algorithm to tell them these are like, we ordered chest X-ray, it was positive. We ordered chest X-ray for this case, it was negative, right? So train that algorithm to understand that. But then when I go to inference case, like in operational phase, now I am like that clinician that is experienced. That clinician that is experienced does not need to have access to these images to say whether I need to, like I need X-rays to make a prediction whether like there is a ARDS case or not. This mathematically, I don't go into details of the mathematics, but we can train algorithms mathematically to make a prediction about things that are not made yet available. You can think of temporally available, saying that like this will be available in the future, or you can think about availability altogether. Think about certain genomic assay or something, ordering some molecular assay that in the lab, in research setting, you can order all of that and you run a study, right? And you order all these assays and collect it for all the patients that are participating in this study, right? And you get clinical data and you get these molecular data. And you train your algorithms like an experienced clinician that sees also like all these like molecular data, right? And you train your algorithm. But operationally, when you give this to people to use it in clinic, nobody has access to the assays that you use for the molecular measurement. But now, if you train the algorithm with privileged learning, with privileged information that we said in here, they don't need to have access to the assay because the information about the assay is in the minds of the experienced privileged learning model that just by looking at other data can predict what could be in that assay that you're not collecting at all, right? And look at the impact of that. I want you to look at this number and this number. This number is the machine learning that is regular machine learning, only looks at the clinical data and makes a prediction whether there is the ARDS or not. This is the machine learning that looks at exactly the same clinical data, but it's trained with the privileged kind of information. None of these guys has access to chest X-ray, but this guy is using it during the training, gets the information about the segmented thing that we did in the previous one, right? Gets that information during the training from the available data in the training, and it pushes in the privileged information. And just by doing that, gets almost 4.5% of improvement. And one thing we don't have in here is the numbers on standard deviation, which are far less for this one compared to that one, which is not only better model, it's far more robust model compared to the other one. If we go to the next slide.
Kayvan,
Yes.
can I ask a question? So I don't know if you had decision sciences on your big matrix of different methodologies, but for decision sciences, we would put this under the umbrella of estimating a prior. And so have you compared these numbers that you have for AUC to what you would have if you asked an experienced clinician? All of this, providing them the same information, but without the chest X-ray. And then my second question is, like, where do you see this going clinically? Is this something where if, say, a day one clinician has this information, can they move to treatment immediately without the chest X-ray? Is it a decision-making support whether or not to order the X-ray? Like, where do you see that next step happening?
Yeah, so as a matter of fact, this data, Mike Shoding, the way he created this data is exactly what you said. Mike Shoding created it, like, he looked at these retrospective cases and he sort of presented this data to a number of clinicians as you're saying that look at the data temporally and tell us when ARDS has occurred.
Okay, so
And
that's
he-
the gold standard.
Exactly
Okay.
like that. And he never showed them the X-ray.
Mhm.
They just look at exactly the same kind of information. So we are comparing that exactly against not just one clinician, multiple clinicians. And we not only did that, some of the data that I'm not presenting in here is looking at inter-rater variability between these clinicians and the robustness of this algorithm compared to the adjudicated, the clinician who looked at all of these and reconciled them. We have more sort of smaller variance compared to inter-rater variability. The algorithm is more robust compared to individual, clinicians.
Great, thanks.
So I guess the question I have though is, I mean, you can do it without the X-ray, but who's not gonna do an X-ray? These kids are, like, they have ARDS, right? So I guess the question that I have is, what's
But can you
that
start-
privileged information
can
that's
you start
actually?
treatment sooner,
Well,
right?
Yeah, but I just feel like that act is not, it's just a given, right? It's like, it's cheap, it's easy, you would get it right away if someone's having respiratory distress.
Or you're
So-
making a decision about whether they have it, or they might be able to make that. This might be able to make the conclusion earlier than a clinician would be.
I'm just saying, would you predicate it on a bigger procedure? Or a more expensive medication, or a more expensive diagnostic tool that's harder to have access to? Right? Because getting an X-ray is simple and
Joyce, I
cheap.
guess to
Is it
layer
fast?
a little bit
Yeah.
of subtlety here, this is Mike's work, not mine, but I think this is within the adult space where two things are true. One, the X-rays actually do exist much less frequently. That's just a empirical reality.
But why is that?
I'm not an adult clinician, I'll ask Mike. But, I think that the other thing that Mike was pointing out is that, ARDS is a diagnosis that's based on the quality of the chest X-ray as well. And there's really bad documented inter-rater reliability on what clinicians actually believe that X-ray shows. And so even with the X-ray, like two people will look at it and come to slightly different conclusions. This is also documented amongst radiologists as well. And so I do think like there's a lot of value potentially in having more uniform ways of evaluating data. But I think that, I'll let Kayvan speak to the broader implications of privileged learning and the broader applications of which he's brought it forward. But I think that this was a place where Mike was able to demonstrate, it was, first of all, it was very aligned with his focus in ARDS and pointing out that there's a lot of poor reliability in how we diagnose ARDS. He was kind of coming to his science just as the Berlin criteria had been brought out, which is like a really large process of diagnostic identification of ARDS in adult patients. And he had worked with Kayvan at the beginning of that work to kind of think about some of that understanding. And then it was also kind of as the EHR was much more coming online, and there was lots of streams of really high frequency and highly underutilized data streams within the ICU. And I think what you are seeing in this work, I think Kayvan I know it continues to evolve over time, but I think you started this work almost 10 years ago, if I'm not mistaken. And so I think this is kind of at the beginning of some of those stages. I don't
It's like
need to
6 years ago, yeah.
This is very interesting. And my crude understanding of AI is not that different from regression modeling, where we're best at predicting the things in the middle of the data set. On the edges of a data set where you have sparse data, we have less reliable predictions. So I'm wondering in pediatrics where we have small populations, we have limited data, what happens to these AI models when you get to unusual presentations or the we're good at, and models are good at predicting the common stuff, but what about the uncommon things?
That is an excellent observation. I would say it depends on the AI, right? This is the lecture that I gave like last week to my AI class. That depends on the metric that you use in your AI, right? If you are using a metric that is focusing on average, these numbers will jump up significantly, but then it will focus on doing an average, very good kind of work. But then you can change your metric. You can change your the measures that you're trying to optimize and focus on marginal cases. You don't want to miss these kind of cases. And then it will, depending on your objective, the kind of cases that you don't want to miss, you want to be better on those. You can train the algorithm to focus on those cases. And that's what we do in some cases. That's exactly what we do, right? In this case, our objective is to predict the occurrence or a diagnosis as early as possible. Our objective, and this is how we measure goodness of the algorithm compared to like these clinicians, like I think in any case, any of these cases was diagnosed by, like assessed by 3 clinicians. We see whether the algorithm can predict the ARDS, true cases of ARDS earlier than the other clinicians. And this is how we measure the success of the algorithm, because we want to predict earlier that we have a case of ARDS, so that we order like chest X-ray to verify that and start the treatment as soon as possible. That's the thing. So it depends on the objective. Yes, exactly. So we talked about this a lot. So I don't want to spend too much time on this because we have to think about how much we're going to talk about other algorithms. I just want to say that we applied privileged information to sepsis as well. And sepsis is also something that you have to act early, like you have to predict it early and act early. And we did a similar sort of approach to sepsis. And Scott Van Epps, some of you, I'm sure you know him, help with this. And we try to look at the data as it comes at a time and try to predict what's going to happen in the future based on treating the data that is coming in the future that's not available as privileged information and move in that direction. This is an ongoing project. It's much younger than the other project and we're still working on it. Emily, maybe you should move faster. Yeah.
Yeah. Awesome. Okay, this is a project that some of you may be familiar with that we were working on with Joe. Now, it wasn't his main project. This was a little bit of a side quest, but we were looking at and trying to, I guess, answer your question of there is a wide variety of pathologies in pediatric presentations, especially in relation to chest-related diseases, respiratory diseases. And there's really limited data, right, that we can, especially as publicly available or even institutionally, to get that data is very difficult. So how can we use other machine learning techniques in order to combat both of those problems? And we use something called transfer learning. And what transfer learning does is we can take adult data, right? So we use a big data set called CHEAR, and it was a whole bunch of adult chest x-rays. And then it was diagnostic labels for all of those x-rays within 6 diagnostic categories of respiratory diseases. So we can train a model on all of the adult data. Now, of course, we can't just take an adult model and apply it to kids, right? That doesn't work very well necessarily. But we can then take a smaller pediatric data set, which is more realistic given the confines of data restrictions, and we can fine tune it on that pediatric data and then see that that enhances the performance of the pediatric data over just like training it on a very small sample size. So there's a bunch of metrics up here on the top right, but you can see for all these different labels, there's 6 labels in the data set. I don't know why only 5 are presented here, but I believe there was 6. Of these, and these were the most common ones, and they went down in, I don't have the numbers here, but there was some that had very few cases, to your point. And we can still see relatively accurate models and pretty high AUCs. Now, of course, for the two in the middle, and especially like bronchitis, we're seeing like much lower AUCs for those. Now, again, small sample sizes to fine tune the model on, that's going to impact the performance, but maybe that's better than no model, right? And we can continue to fine tune that and improve that going forward. These are called GradCam maps, and that's going to show where the model is focusing on to make its predictions. Now, I realize that this is very, very small for you guys. I wish I would have made that bigger, but there's like little boxes here on like the ground truth that talk about where the actual like disease it is that is representative of the actual diagnosis. And you can see these are different models that we implemented and tried to benchmark against. And the red parts are the part that the model is focusing on. So in some of these, like a lot of these are state-of-the-art type models. You can see that it's kind of just focusing on everything. One of them's just focusing on the spine. It's not really learning anything at all. But ours here in red is focusing right where that red box is and is learning to be much more specific in identifying which regions of the X-ray are actually contributing to that disease diagnosis. So while some of those numbers, might be 0.71, 0.74, the fact that we're actually like learning to identify where the disease is very exciting to then give us opportunity to expand on that even farther.
Is the idea that the little area is the only thing contributing, or is the idea that that's the highest concentration of contribution and then it's sort of a gradient across? Because that seems like it would be a really small patch if you think about a disease process.
Right. I think it's where the disease is concentrated. I don't know exactly for these examples, but I think there was artifacts in there that were like the most representative of the disease state. But yes, there was other questions. Yeah.
Yeah, I was just wondering, so when we think about kind of performance of different models and things like that, there's obviously you're showing all of the different statistics.
Yeah.
And I know folks use different ones for different, whatever you're prioritizing, right? So for certain things, I've used an F1 score in the past and things like that. So I guess my question is how do you decide in these particular scenarios and with your kind of learning models, which measure you're gonna prioritize in your building?
Ooh, that's a very deep question. Yeah, we could probably have a whole lot of conversation on that high level. If you, and actually AUPRC is not presented here, but there are certain metrics that are better for when you have imbalanced data than when you have very balanced data. In this case, we were doing a multi-class classification problem, so doing AUPRC was a little bit more difficult, but in AUC, AUC is the one that everyone knows, right? So that's often the one that we talk about. However, I would say that sensitivity here might be a more important metric to look at. Now, of course, AUC is balancing sensitivity and specificity, but if our sensitivity was like close to 0, which means that like the true positive cases, right, which is what we would care about in identifying diseases, right, we would want to make sure that we're not missing people who have disease. We would want our sensitivity values to be really high. Now, we might be able to tolerate some lower specificity in that quest, right? But the AUC and the F1 score, are kind of going to measure some of that all together. But I would look at all of these metrics in combination to evaluate the model overall.
Thanks.
Check the time here, see how we're doing. Okay, so this is a project with Dan Ehrman that some of you might know. It's a very interesting project. I'm going to go through it kind of at a high level in terms of the algorithmic side. But our goal is to develop a closed loop system for managing diuretics after pediatric congenital heart surgery. So you have these neonates and they've just come out of surgery and now we have to balance their fluid. And normally, this is being done by doctors right now, right? But doctors cannot sit at the bedside constantly all day watching these patients, right? So their fluid doses are adjusted about every 8 hours. Now, within 8 hours, the patient can become fluid overloaded or underloaded, right? They can, be hypo or hypertensive. And that has lots of negative outcomes for these neonates. So it would be ideal to be able to continuously, optimally dose the furosemide in accordance with the patient's physiology at that moment. So that ends up being a little bit more of a complex problem, but this is a little different than the other models that we do in that this is more than just clinical decision support. This is a closed loop system, or it will eventually be a closed loop system. So we're taking in data from the patient, like the EHR type data, their blood pressure, how much fluid they're intaking and outtaking, et cetera. And then we are using that based on what we've learned about from previous cases to decide what is the optimal dose. And then we have a whole bunch of safety models that go around that to make sure that we are really optimizing the dose and that we're not putting the neonate or the baby at farther harm. But ideally, then that dose, if it is in agreement with all the safety models, can go right to the pump and be continuously updated so that the dose can be updated every hour and hopefully lead to better outcomes for the babies. This uses a algorithm that we called fuzzy neural network or tropical geometry fuzzy neural network, which is a lot of buzzwords to say that this model is interpretable. You can talk about machine learning models being black boxes. It's like all over the news these days, but this interpretable neural network is interpretable. And this is something that Kayvan and our lab has developed in-house. And what this does is it allows us to, after we've trained the model, we can go back and identify rules or pull out rules as to why the model has made the decisions that it's made. Essentially, what has it learned from all of this retrospective data? And then for a patient at inference, we can identify exactly which rules are firing and are applicable to that patient and understand why the model made the prediction that it made. Very applicable to lots of clinical applications. We used it in, traumatic brain injury and across the board, but this is one, and I see your question, let me explain this real quick. So this is what some of the rules look like, an example here. So this heat map is going to show for each rule, which is the column. In this case, this model has 4 rules, although rule 4, rule 20 in this case is really not contributing much at all. What input variables it's using in that rule, you can see they're relatively simple. So if I were to read off, for example, rule 1 here, or it's rule 18, but rule 1, if urine output is low, fuzzy neural network takes all of the clinical variables that are continuous and maps them into low, medium, and high concepts to make it really simple. If urine output is low and the weight change is high and they are hemodynamically stable, then we're going to, I don't know what the outcome for this was, increase or decrease the dose respectively. Not the clinician, I'd have to check that one. But the idea here is that we could use those rules not only to understand the model and add that interpretability piece, but also have higher confidence in the model, both for the clinician to use it and for adoptability.
I was just curious because
Yeah.
if these are surgery patients, I assume that they're cats, but
Yeah.
there's always like urine output and weight change, I feel like they're kind of interchangeable in some ways, right? And
Right,
so,
absolutely.
and then in some patients, urine output tends to be very poorly measured.
Yes.
So I'm just curious what the relative contribution of each of those are. What's the correlation between those two?
Yeah.
They kind of exist separately, right?
No, that is a really good question. So the darkness of the color is going to show how much they contribute to that specific rule. Now, that's not saying that those variables aren't correlated, because you're right, of course, they are correlated. One of our biggest problems, so I guess that is a higher level, this project was started a couple years ago. This is one of our more successful projects, moving it toward the bedside, at least in the near future. And it's currently in animal studies, but we are also coordinating with a catheter company that does measures urine output continuously. I don't know all the details on it, but so it was going to hopefully solve that problem, because right now it is very variable, and it depends on when the nurse puts it in, and it depends on how it's measured. And of course, that is contributing quite a bit currently to at least this phase of the model that I'm showing here. So we're working on more of that side as well as we're working toward the bedside. Yeah.
I have two questions. They're probably not relevant to anybody else. Number one is the device Zoroflow. And
Is the device what?
the urinary capture device, is it called Zoroflow? Do you know?
I don't know.
Okay. And then my second question is, at any point during the kind of development of this, was any kind of kidney measure included in the possible like choices, and they just didn't rise to the top?
Yep, absolutely. That physiology safety model is almost all like, kidney related. Yes, absolutely. Good questions. All right,
That's me. Don't worry about it.
okay, great. Okay, I'm gonna jump through one more thing here in like 3 minutes, so we have a couple minutes for question and discussion here. This was another project with Joe, that again, not his main project that you guys are probably more familiar with, but another side quest. And Joe is very passionate about also about neonates, and especially in the diagnosis of NEC. So NEC is very similar. You guys are a room full of clinicians. You guys know this, similar to ARDS, right? It's a little hard to get clear diagnosis in that, you could have 5 radiologists look at the same x-ray, and they might all have different decisions about whether or not there is presence of NEC features. So in order to combat that, as well as the time delay, obviously time is of the essence when a baby has NEC or a child has NEC. So how can we, at the bedside, have a prediction of whether or not we think that this child has NEC from the x-ray without having to wait for the radiological interpretation, which in some rural hospitals, of course, might be the next day, right? And if they don't have NEC, then you're not feeding them, and there's like a whole bunch of negative consequences that could come from that. And if they do have NEC, of course, you want to start that treatment right away. So maybe it's not a ground truth. Of course, we still need the radiologist, but how can we maybe get an inclination at the point of care as whether or not this child has NEC? In order to do that, it's kind of a 2-stage process, but I'm showing step 1 here. Step 1 was, how do we actually get labels for training something like this? Of course, that's the hardest part when labels are uncertain, just, inherently, because like I said, you can have 5 radiologists look at the same thing. And if you pulled it out of electronic health records, you'd get some variation there as well. So we used radiological ground truth and the radiology reports from the past, and we needed to extract out labels of the measure of uncertainty as well as the presence of NEC features. So while a couple radiologists might have different decisions on whether or not a patient has NEC, their observations of the artifacts related to NEC is a little bit more consistent, right? Like, this is what they're trained to. They can identify, and maybe they're still uncertain, and maybe you could ask 5 of them, and if they had to give a binary yes, no, you'd see lots of variation. But if you were to say, okay, well, I saw this, this specific presentation and this specific presentation, and then like, I'm still uncertain about the NEC diagnosis. Long way to say that we trained a large language model to pull out the presence identified in the radiology report of all of the NEC features, as well as measures of uncertainty. So if they we see this presentation, but we're not sure if it's NEC, or it could be this, or it could be that, we were able to measure that uncertainty using this large language model to create a large comprehensive database of, I believe it's to date, it's the biggest one that exists so far, of labeled radiographs for the presence of NEC features. So that's stage 1. Stage 2, which we just submitted a grant to do, is now, okay, can we take those labels and those uncertainty metrics, and can we now train another machine learning model to take the x-rays themselves and predict whether or not there is NEC in this x-ray? So long process to get there, just given the limitations on the data and the uncertainty in the labels, but we're really excited about where this project can go. We have, Kayvan, about 9 minutes till we're
Yeah,
done. And then we think
I quickly
pick 1 or 2 and we can take questions.
I can quickly talk about general. So we want to tell you about other projects that we do in the lab. So we work on, so this is something that we did with Department of Defense, predicting of cardiac events that can happen post cardiac surgery. And we had like, really that was one of the most successful projects in the lab that predicted like, cardiac events up to like 12 hours ahead of like, the event. And not just like, specific surgeries like, cardiac surgeries, we actually applied that to later on, we use the same model without retraining to like, orthopedic surgeries, like cardiac events that happens after orthopedic surgeries. And they were like 85% like, AUC of predicting events. So that's like something that we're still working on it. We have a ton of work that we are putting on video analysis for endoscopic videos for UC and Crohn disease, and we basically analyze all the video, identify all kinds of, presence of blood, like, erythema, presence of like where biopsy happens, what kind of abnormalities happen in the video, estimating all kinds of severity measures that are out there, and we turn that into a company. One of the companies that actually see there, like, in my disclosure is one of like, the outcomes of this project. For the last 25 years, we work on traumatic brain injuries, all kinds of, analysis for assessment of all kinds of outcome related to that, estimating of like ICP and all kinds of things related to traumatic brain injury. Emily's project is stroke and analyzing the data for stroke and management of surgical planning for stroke. And two projects related to ventilation that are, one of them is like Joe's project, Joe Coney, who left it halfway, like, like in the project and left university, but that's basically assessment of, for pediatric cases, when we're going to basically move away from like ventilation and prediction of the time that we move away from mechanical ventilation. And we're doing with Dan Ehrman, his controller, to like, do the process of winning on ventilation. And Lisa knows that we're hosting a national center here called DATA, Data-Driven Drug Development Treatment Assessment. And that is AI for design of drugs and basically assessment of drugs for treatment assessment. This is essentially maybe 50% of what we do in the lab right now. And that's like the part that I didn't talk about it. And that's essentially using AI to design large molecules, small molecules. We design a lot of therapeutic antibodies. Recently, we designed an algorithm for that. And that algorithm that is like being patented resulted in a couple of molecules, new antibodies that are, one of them is for psoriasis that like we're testing, universities looking into patenting those molecules. And we are, National Science Foundation has helped us design like a bunch of transparent algorithms for management of heart failure. Emily talked about one of them. And in the end, like, we are very enthusiastically working on a project that is helping our colleagues manage preterm birth and try to predict when preterm birth is happening and try to essentially like, not only make the prediction about that, like also create an LLM that answers the details of what's going to happen in the last few weeks of pregnancy, and like create a system of like, communicating, like AI answering question about individual like pregnant mothers, like expecting mothers, about the complications that can happen. And we just submitted another proposal to National Science Foundation for the algorithmic development related to that. So these are examples of the projects that we have. And we love to hear about, what you want to know about, like the lab, the techniques, the algorithms, or the projects that you want to work with us.
Yeah.
Thanks for coming. This is really interesting. And one of the reasons I wanted to have you guys come and talk is because I think a lot of us, a lot of our faculty do research that involves, some of us do the kind of the clinical decision-making stuff. Some of us are also involved in more, kind of bread and butter questions like, why do some kids get high quality care and others don't? Why do some kids with sickle cell disease receive preventive care that reduces complications and others do not? So there's obviously all of these methods that you use, kind of are general. They're kind of agnostic to the content. And I wanted to hear a little bit more about kind of your process, or your willingness to kind of talk with us if we have an idea for that, and then kind of what your criteria would be for establishing a collaboration. Because I know that you had talked to me about sometimes really wanting a concrete product that can either be used in clinical practice or commercialized as one of the things that you kind of consider as you're contemplating whether to establish a collaboration.
Absolutely. Exactly what you said. To me, a project, so remember the thing that I mentioned, like people ask me, what do you do? I say like, I'm a bounty hunter in the world of medicine. Like I protect the walls for problems that are important enough to go after, and whether I can do them or not, I can do these projects or not. So first, it has to be challenging enough to worth the attempt. It has to be exciting enough. It will have an impact that like I feel like, if we go after it in the end, if we solve it, it will have an impact that I feel like I've done something, that I'm proud of. The other thing is obviously whether these bag of tricks, the tools that I have in there, like, AI things that I can do, have the potential to solve, right? If you tell me like do the impossible, I know that I cannot do it. So it's basically, it's exciting enough, it's impactful enough, and whether I can do it or not. Obviously, in the end, we love to publish and everything, but to us, we want to make sure like there's at least some entity interested in bringing that to bedside, as opposed to like it's helpful for someone, as opposed to just like making publications. I really don't want citations or publications. Just it's good to have publications, but to me, it's important to make sure that somebody will end up using it. Even if you make it like, a free software that will be used, like, doesn't have to, you don't want to necessarily make money out of that. We just want to make sure it's used by someone. That's our criteria, very simple.
And maybe I can add to that of like, a lot of these projects are motivated by one step down the process from what you're talking about. So we've identified that there is a disparity in health. And like for Joe's project, right? Like the kids at Hurley, they don't have ECMO at Hurley. So like if they are going to progress and get worse, they're going to, decline, we need to get them down here early before they're too sick to be transported. Otherwise, there's like already this disparity in care, because just because you went to Hurley doesn't mean that you shouldn't have life support, right? So some of these have been motivated by those disparities that you're talking about. And then now we're trying to like figure out how can we provide more equitable care, and how can we start to solve some of these problems by introducing decision support. So I think both, and like it's very like those are really interesting questions you're talking about. We can definitely like, I can speak for Kayvan. I'd be happy to like talk about them if you like, jot down our email, or we have a QR code with our website. But if you want to reach out, at least like we can talk about your question, right? And like maybe our methods may be the right methods and maybe they're not, but we can at least point you in the right direction.
Absolutely.
Yeah.
And remember, I'm involved in Midas as well. So if I'm not the right person,
Yeah.
I can always find someone in Midas who can help you, right?
So what is the distinction, I guess? What is the distinction between what you guys do and what Midas does?
Distinction, I don't know what you mean by distinction, but our lab is focused on clinical decision support systems. Like we do AI for medicine, but Midas does so many other things like social sciences. Midas does like, engineering, whatever, right? So, but my role in Midas is not just to do what I'm doing for the lab, right? I go to dental school and I go to pharmacy, nursing, and I promote like education aspect of that, right? So my role for Midas is not limited to do these like projects that I like, right? I do projects that I like in my lab, right? And I'll be happy to do as much as I can within the scope of my lab. But sometimes the projects that people want me to do, I feel like there are others in Midas who can do better. And that those cases, I refer them to other people in Midas. But if the project falls within the scope of my lab, I'd be happy to help, right?
I realize that we are over time. But I mean, I'm willing to stick around for a couple minutes. I'm happy to chat, or like I said, please reach out to us via email and we'd be happy to talk to you about your projects. But thank you so much for your time and for coming in on an early morning here. It was lovely to talk with you all, and these were really great questions. So we're excited to hear from you all.
Thank you.